Good evening everyone, how are you? Hope you are doing good. I am Dr. SULTHAN and RASHID. I am a diabetologist and also a pharmacologist. Today I am going to discuss about one of the important topic, that is management of diabetes in hospitalized patients. Let's go into the topic. As we know, hyperglycemia is common in hospitalized patients and it predisposed to worse outcomes and greater complications. The prevalence of elevated blood glucose levels during the hospitalization is not well established, but it may exceed 30% of inpatients at tertiary care medical centers, with 1/3 of cases occurring in people without a prior diagnosis of diabetes. So the rates of hyperglycemia are particularly high in persons with critical illness cared for in intensive care units, where the blood glucose levels can correlate with the severity of illness. Depending upon the patient's population, a significant number of patients with the first detection of hyperglycemia during the hospitalization, they will have persistent hyperglycemia after recovery, and they meet the diagnostic criteria for diabetes. The stress of illness has been associated with the insulin resistance. They often attribute to the counter-regulatory hormone secretion, cytokines, and other inflammatory mediators, although the role of specific mediators has not been proven. Medications used in the hospital like glucocorticoids or dextrose containing intravenous solutions, they can exacerbate tendencies towards hyperglycemia. Finally, fluid balance and tissue perfusion, they can affect the absorbance of subcutaneous insulin and the clearance of glucose. The therapy of hyperglycemia in hospitalized patients should be adjusted for these variables. Insulin is the cornerstone of treatment of hyperglycemia in hospitalized patients. Oral agents, they have a limited place in treatment of hyperglycemic patients in the hospital because of slow onset of action, insufficient potency, variable absorption from the gut, and side effects. In non-critically ill hospitalized patient, what we can use? A basal plus bolus correction insulin regimen should be adjusted for oral intake is optimal. There is evidence from randomized trials that using only short-acting insulin in response to hyperglycemia, that is sliding scale regimens, is very less effective than scheduled insulin regimens. For the critically ill and those with variable blood pressure, edema, and diminished tissue perfusion, what we can use? We should use only intravenous insulin is the treatment of choice. Intravenous administration of the insulin also is well suited to the treatment of diabetic patients during the perioperative period and during childbirth. So what blood glucose target we have in hospitalized patients? Although optimal blood glucose targets in hospitalized patients are incompletely defined, in general, the levels of 140 to 180 mg per deciliter in most hospitalized patients, with more stringent goals to 110 to 140 mg per deciliter in some critically ill patients are recommended. Thank you so much for your kind attention, and kindly share my lectures to your friends.